And a lot of times in endodontics that isn't happening, because you know what's going to happen when you look at this on a cone beam, right? So, not to repeat the point, but remember, diagnostic accuracy cannot be defined independently of interpretation. There's an intervening interpretation that goes on. You can't have a machine reader just read the radiograph and say there's disease here. There has to be an interpretive background that you bring to this process that lets you achieve diagnostic accuracy. Okay. When we talk about domain expertise, I'm going to talk about it more in the second part, but basically when you talk about domain expertise, you're talking about competence. Well, what do we mean by competence? What does competence really mean? And there's a very specific definition of competence. And the definition refers to expertise is measured by the degree to which errors are reduced. Competence is related to reduction of errors. So we're going to focus on errors because this is where the big misunderstanding is in dentistry. If you're going to talk about errors, let's categorize the errors. What kind of errors are made? What is the quality of those errors? Not only the quantity. A lot of people say, well, you do a root canal, you don't. You have periodontal disease, you don't. It's just you're either right or you're wrong. But that isn't actually the error, that isn't one error. Errors, you have to know how errors are classified, and to do that you use the language of statistical testing. So we're going to go into the types of things that Steve talked about this morning. There are basically two kinds of errors that you can make, and they're different. These two errors are different kind of error. The first is failing to find disease when it's present. The second is finding disease when it's not present. Those are two different errors. Not one error, two errors. So what kind of error was this on Cindy's case? There was disease there, but I didn't find it, right? That's one kind of error. And we have names for these errors now. That's called a false negative. And we have these type 1 and type 2 errors. People really struggle with this. I've struggled with it. You have to think, let's see, false negative, false positive. It's easier if you just think about a type 2 error or a false negative error as extreme skepticism. That's how I think about it if I'm trying to figure out what kind of error. I saw this thing. I think, oh, well, maybe it's the anterior foramen. I don't think this is anything. I saw this, but I didn't believe it. I was skeptical of it. That's a type 2 error. To draw an analogy, you're in the shower, your wife's cooking you breakfast in the kitchen, you hear the smoke alarm goes off, you say, oh, damn, she burned the toast again. You don't believe the alarm when you hear it, okay? Extreme skepticism. You fail to see the wolf at the door using the screening at the airport. The alarm goes off. You look at the guy, he's got a huge belt buckle. Oh, it's not, he doesn't have a bomb. It's a false alarm. Okay? Extreme skepticism about the result of a test. That's a type 2 error of the second kind. Cone beams tend to reduce type 2 errors. Why? Well, you know why. Whoops. You know why. I'm looking at this. I see it on a cone beam, and it looks like this. So cone beams tend to reduce this sort of error. But, and you might say, well, why don't we just take cone beams? You're going to pay a price for that, though. That's what I need you to understand. You will pay a price for reducing that error. And it's very important that you understand what that price is. So let's look at the second type of error, finding an abnormality when it's not present. This is a case from Sachinalapati that he posted on our chat group. What's this? It's a fracture, right? You're finding this fracture. The problem is it isn't fractured. You're finding disease that isn't present. You're finding, you see the abnormality, you see this abnormality, which is just a reconstruction artifact. You see this abnormality and you believe it. So type 1 errors are errors of extreme credibility. The alarm goes off and you believe the alarm, okay? He did the root canal and the fracture miraculously healed all by itself. Cone beam technology, cone beam imaging is especially susceptible to these type 1 errors. And all kinds of overtreatment is being done because alarms are going off and the people believe those alarms. They're seeing fractures, they're seeing abscesses, they're seeing disease, when in fact many of these things are not present. So a false positive is a type 1 error, an error of extreme credibility. The alarm goes off and you believe it. The smoke alarm battery goes off and it makes a signal. You hear it, oh my God, there's a fire. You believe a signal that isn't really true, okay? You cry woof when it's only the coyotes at the door, okay? Guy comes through the screening with a big belt buckle, the alarm goes off, you say, oh my God, he's got to have a bomb. Those are type 1 errors. And cone beams tend to increase type 1 errors. This is just one of the papers. It's kind of the poster child for this. Axial slice clearly shows the vertical root fracture. I don't think so. An error of extreme credibility. The endodontic literature is filled with these kind of errors. Almost every single one has these kind of errors. Is this making sense to anybody? I don't know if I'm boring you or not. I'm not going to go through all these papers. Almost all of the papers that claim a superior diagnostic accuracy for cone beam imaging are filled with this type of error, both because they don't understand how the image is reconstructed, or because the target group that they're testing on, the prevalence is so high that you'd find that. So, let's have a pop quiz, because I know most of you are sleepy after that wonderful lunch. What kind of error is this? Don't answer, John. This is hard to do. It's both. He made both errors. He detected disease where there wasn't any, and he did treatment on a leg that didn't need it, or a kidney. I guess was it kidney? Yeah, kidney. So both errors are made, both at the same time. A type 1 and a type 2 error. So now we're going to talk about the hard part, sensitivity. I have much greater sympathy for John Cotomy in trying to explain what this is, because he did this at TDO and he did it beautifully, but this is really hard to do. So sensitivity is easy. It's just correctly identifying disease in patients who have disease. In cone beam imaging, what does it mean? Correctly identifying an abnormality in patients who have an abnormality in the imaging. Correctly identifying abnormality in patients who have abnormality. Specificity is correctly identifying health in patients who are healthy, or correctly identifying normal findings in patients who have no abnormal findings. That's what specificity is. So a perfect diagnostic test has the potential to completely discriminate subjects with and without disease. So what would a perfect test look like? What would it look like? This is what it looks like. If you take a look at these two distributions, let's say you're measuring some parameter in the blood that can tell you whether you have cancer or not. When you measure that, people that don't have cancer will have a distribution of those findings. Not everyone has exactly the same value. Some patients, there's a distribution of values in patients that have cancer. And there's a distribution, or that don't have cancer. There's a distribution of values of whatever parameter you're measuring in patients that have cancer. And if these two distributions are far apart, drawing your decision threshold of who to treat and who not to treat is really easy. You draw it here, you'll never treat a patient that doesn't have disease, and you'll get all of the patients who have the disease. Let's go make perfect tests, right? Then our job would be really easy. We would find certain parameters where these two distributions are really far apart. In imaging, let's not call it cancer and not cancer. Let's not call it health and disease. Let's just call it normal and abnormal. So we need to find parameters that are far apart that we can measure, and if we do that, we'll never make a mistake. We'll never make a mistake. So let's use an example. Let's imagine that we're from California and we're working in our garage late at night at 2 o'clock in the morning when everyone else is asleep, and we have found a peptide that predicts bone loss. You go into the gingival sulcus, you find this peptide, and you've tested these patients for 10 years, and now you realize a stunning fact, that if any patient that has a reading of 100 milligrams or less, they never get bone loss. And any patient that has 101 or greater, they always get bone loss. What would that test look like? It looks like this. Now your decision threshold is really easy in perio now. You have a test that tells who's going to get bone loss and who doesn't. And it's based simply on this one parameter. It's 100, no bone loss. 101, what a great test, right? Unfortunately, we don't have any tests like that. There might be in medicine, I don't know. In dentistry, I don't believe we have a single test where these distributions are so far apart. They always overlap. So values above the cutoff point don't always mean disease, and below the thing, they don't always mean health. So what this does is it separates the decision threshold into identifying 4 possibilities. And these are true positive, true negative, false positive, and false negative. So right off the bat, if you look at it as a distribution, you will be able to either minimize or maximize your type 1 and type 2 errors. You can do a little table that keeps track of them. I like to look at it like this. This is from John's master's thesis. And this is more what a real test actually looks like. There's some crossover. Some people that have normal values, some of those have a value, say, in this area. Those people could be either normal or abnormal, right? They're in this crossover area. Now, it would be like, let me give a perio example. You do an average of periodontal probing, let's say. That's not a good example, but yeah. Does everyone who has a 6 millimeter pocket need perio surgery? No, some do, some don't, right? So there's always this gray area where it could be either or. Now in John's thing, see, I had a hard time with this initially because this is confusing to me. There's too many lines. I'm an endodontist. I work on one canal at a time. That's why I'm an endodontist. I don't have to think about, I got to think too many things here. I can't figure it out. So let's separate them out. Okay? This is the abnormal distribution down here. This is the normal distribution, and they're overlaid. They don't they're not separate like they were before. You pick one value. Let's say I want to make my decision threshold so I get all of the abnormal, I get most of the abnormal ones, so I'm going to pick this value right here. And then if you go up here, you're going to say, well, this is great. I'm getting most of the diseased cases, the abnormal cases, but what price am I paying for that? Half of the normal people are getting they're getting treatment recommendations. That's not a very good trade-off, unless you're comfortable with that. So when you choose a low threshold, let's take your peptide test. I'm not going to, and this is the actual overlay of how close normal and abnormal are. Instead of 100, I'm going to choose 70. If I choose 70, I'm going to get most of the abnormal people. But the trade-off is I'm going to treat half of the people who don't really need it. That's by choosing a low threshold. This is how John put it in his master's thesis. To maximize sensitivity, that is, you don't want to treat any, you want to get all people who actually have disease. So you put your threshold right there. These are the people with disease. These are the people that are abnormal. You make your threshold here. Well, all of these normal people are going to get lumped in with the abnormal people and have treatment recommended to them. That's an error, isn't it? That's a diagnostic error that you're making. Same thing here. If I don't want to make any mistakes with normal people, I make the decision threshold here, and these people who are abnormal are going to be missed. Okay? If this is breast cancer, it's a problem, right? So if you choose a high threshold, you're going to miss some abnormal people, but you won't subject many healthy people to a problem. So the point is that there's trade-offs here. In imaging, what are we going to do with this? What kind of a threshold do you want? Because this is part of the interpretive process that goes on. So whether you treat this or not depends on where your threshold is. And that depends on your tolerance for error, either type 1 errors or type 2 errors. Now, it turns out my tolerance for error, for sensitivity, is pretty low here. This tooth had this endodontic surgery done 30 years ago. This abnormality, this image that's perturbed, hasn't changed in 30 years. So I'm going to be extremely skeptical of this test. I'm not going to think that this is a pathosis, or at least a pathosis that the patient benefits by having eliminated. On the other hand, if I have some other prior information, and this perturbed image here looked perfectly normal 3 years ago, now I'm going to give this test some credibility, and I'm going to be less tolerant for the kinds of errors that were made previously. So if you choose a high threshold, you're not going to end up treating a lot of normal patients. This is my case. I did these root canals 20 years ago. Patient is now 82 years old, insulin diabetic, overweight, not in good health. This image is perturbed. Maybe even this image is perturbed. Where is my threshold going to be? Well, what is my tolerance for the sensitivity and specificity? Because that was the original radiograph. So I don't want to just look at this and say, you know, I see a lesion, you need treatment. And that's typically what happens in endodontics. Doesn't matter if there's any symptoms here or what happened before. You've got an abscess here, maybe you've got one here, we've got to do surgery. Maybe think this has anything to do with it, John? Okay. What does a low threshold look like? A low threshold means I don't want to miss any disease. This is what I call a low threshold. I have extreme credibility. Oh, this is abnormal. It must be disease. This is extreme credibility. I'm believing that this is disease. What does that mean? It means I'm not going to miss much disease, but if this really isn't disease, I'm going to treat a lot of people who don't need treatment. And I can tell you, I kind of have my finger on this in the endodontic thing. This is rampant in endodontics. These people are being treated because there's a finding on a radiograph where they're inferring that there's disease. It's very sad to see. So these are low thresholds. What about this? See, we don't know what normal is. This is our problem. We don't have domain expertise. I don't know if this is a lesion or not. The tooth's in traumatic occlusion. Maybe this is what teeth in traumatic occlusion look like on a cone beam. I don't know that. To know that, I'd have to look at 10,000 cone beams where there was a high number of traumatic occlusions or orthodontic movement to know what normal is. Yes? I don't know that. We don't have that expertise yet. What about this? It's a lesion, isn't it? No, it's not. You know why? Because I did this root canal. Okay, can't be a lesion. So your interpretation is flavored by the prior information. I'm seeing this a lot on my recalls. We take cone beams on all the recalls. I'm seeing this. Do you think I'm going to go in and retreat all these cases when there's no symptoms? No. I mean, a man's got to eat, but come on. Okay, so that's what a low threshold looks like. And it doesn't even have to be pathosis. It really goes to the extreme credibility or extreme skepticism. I need to know whether if I go into this tooth, if I can get into this canal. Now, do I believe the cone beam that I took here? Is this evidence of a canal being present or isn't it? It might determine my decision whether I want to go in. If I see it, yeah, I'll go in, I can find it. But what if I don't? So I need to make a call on this, and there's uncertainty involved in that call. And depending where I draw my sensitivity specificity line is going to determine how I evaluate this radiograph. So what I'm trying to get across is that with one single cone beam volume, the sensitivity and specificity may vary with the threshold. This is another one of my cases at 1 year recall. Whoops. Yeah, it's perturbed. The image is perturbed, but I'm not prepared to say, now if you did the case, that's different, right? That's a different prior. But I did this case just a year ago. So we need to be careful. Same thing here. What do you think? Can you see this, or do I need to blow it up like I am? Does that help? What do you think? Is this perturbed or not? See, so how you view these things is where you're going to make that decision threshold, and what is the determination of that? The determination is, what errors am I prepared to make? So what you're thinking in your mind is, I have to make a choice between a type 1 and a type 2 error. Which one do I want to choose? What am I comfortable with? Treating everyone who possibly has disease, or making sure that I don't treat anyone who doesn't really need it. My thing in my office is I don't want to treat anyone who actually doesn't need treatment. So my thing is way over to the right. It's a very high threshold that I need to treat a patient. It's a high threshold. I think in endodontics generally, with people using cone beams, especially people who don't know how the image is actually reconstructed, they're using a very low threshold, and it's a problem. What about this? So you get the you get the point. This is another tooth in traumatic occlusion. Is there anyone in the room that has enough experience reading this to know whether this is within a normal range or not? No, there isn't. Unless I'm missing something. Again, same thing. What kind of type 1 and type 2 error are you going to, where do you come down on? Do you want to treat people who don't really need it? Or are you afraid of missing any disease and having the patient come back and sue you because you missed something? See, that's the trade-off that you have to be thinking about. Okay, so just to briefly describe ROC curves, because this is really how you figure it out, and this is really what John's master's was so good at explaining. Let's say you have your perfect test. Okay, this is our perfect test. How do we draw that ROC curve? And don't let this ROC curve confuse you. All the ROC curve does is it lets you understand the trade-off between doing too much or not doing enough. That's all it is, between type 1 and type 2 errors. So if you had a sensitivity of 1 and a specificity of 1, you'd be right here. You treat all cases that have disease, and you don't treat anyone who doesn't have disease. This is the perfect test. This is the point on the ROC curve. Medium sensitivity, you're not going to treat many people who are healthy, and you're going to get half the people who are diseased. So you have medium sensitivity. It's a high threshold. That's what I have in my office. It's a high threshold. I don't want to treat anyone who doesn't actually have to have the treatment. That's a high threshold. But it's medium sensitivity because you're going to miss people with disease. Okay, so that goes here. That point goes here. Continuing, so you continue on by changing this decision threshold to the left, to the right. Remember, to the left, no treatment. To the right, treatment. As you change the trade-off between treating and not treating, these points come up in an arc, and that's called an ROC curve. Okay, and that's what these ROC curves are. So the way you use an ROC curve is you determine a specific sensitivity or specificity, then you draw across to the thing and see what price you've paid for that choice. That's all it allows you to do. What price am I making between type 1 and type 2 errors? Do I have this right, John? Kind of. Okay. I'm learning this too, so forgive me if I'm not explaining it very clearly. So ROC curves are very, very powerful to understand sensitivity and specificity. That's all they're really used for. So Dr. Birbaum says, ROC is a useful tool to help distinguish the intrinsic detectability of the signal, which is a sensory variable, from the decision criteria, which is a matter of judgment. And I hope I've made that clear. It's a matter of judgment. What errors and what kind are you prepared to make as you move this decision threshold back and forth? Oh, I don't have a...
You can't really know one without the other. Even if that's all you're going to do in your scientific paper, you have to know both. And when I say know, I mean that you have to have the same amount of evidence for both. A very common problem of people trying to do research and report sensitivity and specificity is that they take a sample of interest and they go to a great deal of trouble getting a good gold standard, and they find out at the end of it that 95% of the cases that they studied had the disease. Well, that's really good from the point of view of specifying what sensitivity is. It gives you a very narrow confidence interval, the space where you're